Namaskar, welcome to today's Critical Care Lines podcast. And today it is my great pleasure to welcome Dr. Ramesh Venkataraman to our podcast. So, sir is known to many of you who may have been part of his teachings. He is one of the great luminaries in intensive care in India and a great educator for all of us. So, just to introduce Sir to all of you who may not know him, he is currently senior consultant at Apollo Hospitals, Chennai, India. Apollo Chennai is one of the great hospitals in India and one of the great ICUs in our country. Sir has received his basic education from United States of America. He's qualified in medicine, in critical care, and in neurocritical care from United States of America. While in the United States of America, he won many awards, including the Best Teaching Award for the Resident in the year 1999 from University of Connecticut. Then he was also awarded Fellow of the Year at University of Pittsburgh, and at the same university, he was awarded Faculty of the Year in Critical Care in the year 2006. Subsequently, he was awarded two presidential citations when he returned to India from the Indian Society of Critical Care Medicine and Indian College of Critical Care Medicine for his contributions to teaching and education in our country. He has over 100 publications, including papers and books. And I think today will be a wonderful session learning from Professor Dr. Ramesh Venkataraman, sir. Sir, so shall we start with your permission?
Yeah, thank you so much, Dr. Tapesh, for the nice introduction. Yes, I'm very happy in this venture. I think you've been doing a great job and it's a great resource for the trainees. I'm happy to be part of it. Go ahead and get started, please.
So the first question, sir, for you to throw light on is, what is the current thinking on transfusions in traumatic brain injury?
Okay, so traditionally, when we talk about blood transfusion or packed red blood cell transfusion in critically ill, we originally quote the original TRIC trial, TRICC trial for the trainees published in 1999, where a Canadian group basically randomized patients to a conservative arm where the hemoglobin was kept around 7 gram per deciliter or 10 grams per deciliter, which is just the convention of how people used to transfuse in those days. That study clearly showed that 7 grams per deciliter was as good as 10 grams per deciliter. There was no differences in outcome. And obviously, the complications related to transfusion, the number of blood cell packs used, the cost, everything was lower in the conservative arm. And since then, in critical care, a conservative strategy of around 7 grams per deciliter has always been at the target. This has been replicated in other diseases too. But most of the studies that have actually looked at blood transfusion targets in critical care have excluded patients with intracranial injury, specifically traumatic brain injury or subarachnoid bleeds or intracerebral bleeds, because they felt that the targets there may be variable and they didn't want to harm anybody by including them in those studies. So there's always been an unanswered question in terms of what transfusion target should I give somebody who has a traumatic brain injury or one of those other reasons to have the brain injured. And the reason I wanted to answer this question particularly is because there have been three new trials, I think, in the last 6 months that have shown a lot of light in this particular area. One, in brain injury, there is always going to be impaired perfusion to the brain. So the more the oxygen that we deliver to the brain is going to be better. So a 7 gram or a conservative approach may not be the right thing to do. On the other hand, if I just empirically transfuse everybody to 10, I can push them into pulmonary edema, TRALI, cardiac pulmonary fluid overload, and things like that can happen. So this became a very important question, especially in an injured brain where the dynamics of perfusion are different than what we see elsewhere. The first study I want to just bring up is the Sahara trial. Sahara trial was done in patients only with subarachnoid hemorrhage. 74 patients randomized to a hemoglobin target of 8 gram versus 10 gram per deciliter. They found that the liberal transfusion, which is 10 gram per deciliter, had a trend towards improved outcome rather than the 8 gram per deciliter. And more importantly, patients who were kept at 8 gram per deciliter had a higher chance of developing radiographic vasospasm, which is bad in subarachnoid hemorrhage. So that was one of the first trials, but that was pretty much in subarachnoid hemorrhage. The next trial that looked at clubbed all brain injured patients. It's called the TRAIN trial, where they looked at about 800 odd patients. They combined patients with subarachnoid hemorrhage, intracerebral hemorrhage, and traumatic brain injury. About 60% of the patients in this study were traumatic brain injury. They randomized patients to 9 gram versus 7 gram per deciliter, and they found very good neurological outcome in the liberal arm. If you keep the hemoglobin around 9 gram per deciliter, the outcomes were different, with an absolute risk reduction of almost 10% in terms of the functional outcome of these patients over a period of time. So you can say that, okay, this is a study where they clubbed everything, including TBI, SAH, and ICH. The most recent trial is called the HeMotion trial, where they included only patients with traumatic brain injury. They randomized patients to 10 gram versus 7 gram per deciliter, and they found that the chances of unfavorable outcome, neurological outcome, was lower in the group that got the liberal transfusion strategy, which is 10 gram per deciliter in this particular trial. The complications rate that was reported across the trials were not significantly different between the two groups. A previous study that looked at erythropoietin and traumatic brain injury showed higher incidence of thromboembolic events with erythropoietin. However, these studies did not show a similar risk factor in patients with a liberal transfusion strategy. So if you put all those studies together, the original Sahara study, the TRAIN trial, and the HeMotion trial, there seems to be a positive benefit with the liberal transfusion strategy in brain injured patients compared to a conservative strategy. Going by the three studies right now, all of us would probably accept that we should probably keep a hemoglobin threshold of 9 gram per deciliter rather than 7 grams per deciliter in patients with brain injury, especially definitely in patients with traumatic brain injury. Maybe SAH and other things, we probably need a little bit more evidence, but there is reasonably consistent evidence in traumatic brain injury that a hemoglobin of 9 or higher would be better in terms of the neurological outcomes. Thank you, Dr. Tapesh.
Thank you, sir, for the answer. And moving on to the next point. So there have been some recent advances in CIRCI and cortisol metabolism, sir. So can you elaborate on how to diagnose and manage critical illness-related corticosteroid insufficiency? That is CIRCI, sir.
Okay. Thank you, Dr. Tapesh. Again, a very interesting, very common question we use in the ICUs. It's probably better if I just narrate the sequence of how the evidence evolved over a period of time. Although a few studies thought immunomodulation in sepsis is useful and steroid is considered immunosuppressive and sepsis is considered a hyperinflammatory response kind of a state, a lot of people over the years have thought that giving steroids is a good idea in sepsis to kind of modulate the inflammatory response. There have been some studies done in 1960s and 70s, which I will probably not go into the detail, but in 1980s, people felt that you giving high dose of steroids, which is 30 milligram per kilo of methylprednisolone, which would be about 2 grams of methylprednisolone at the current 70 kilo man, was actually good idea because they thought they can suppress this immune response and see if the patients would do better. There have been about 3 or 4 studies that have tried that. Unfortunately, all of them did not show any significant outcome benefits. In fact, showed a little bit more harm in patients who got such high doses of steroids in the 80s. Then the understanding of cortisol and its metabolism and critical illness changed a little bit. Then they said, okay, there is going to be some amount of suppression of the hypothalamic pituitary adrenal axis that happens in critical illness, number one. Number two, cortical sensitivity to the receptors goes down, and therefore there is a relative cortisol deficiency that happens in any form of critical illness, and therefore maybe supplementing this hormone may have benefits. What happens when the cortisol relative insufficiency or absolute insufficiency happens is that the sensitivity of the alpha receptors and beta receptors, where when we use vasopressors or inotropes, goes down. So the effect or the benefit that we get from vasopressors is blunted and the patient continues to be in shock. So for this reason, they felt that we need to replace the physiological doses of steroids in patients with sepsis. Okay, so then the question is, how do I diagnose it? The first study that actually looked at is the unnamed study done in early 2000s or late 1990s, where they did the ACTH stimulation test. They gave patients 250 micrograms of ACTH. They did the cortisol at baseline and about 1 hour later. And they showed that if you had a rise of more than 9 micrograms per deciliter after the ACTH dose, they called you a responder. If you did not have that kind of a rise, they called you a non-responder. They randomized patients irrespective of their responsiveness to hydrocortisone plus fludrocortisone for the mineralocorticoid activity versus placebo. They could not show an overall outcome benefit in the entire population, but in the subgroup of patients who were non-responders, where I gave ACTH and their cortisol did not increase by more than 9 micrograms per deciliter, there seemed to be an outcome difference in terms of survival and getting them off the vasopressors. So there, the story started saying that maybe I can use an ACTH stimulation test to try to identify people who have suppressed HPA axis in critical illness and maybe target my steroid therapy only towards those patients. Subsequently, as we unraveled the physiology of cortisol, we found a few things. One, 250 micrograms of ACTH was an industrial dose. It's a much higher levels of ACTH than what the body produces at stress. So a lot of people said, oh, when you give that high dose of ACTH, invariably any adrenal gland would probably respond, and maybe we should not give that kind of a dose. So people went to a low dose ACTH stimulation with 1 microgram rather than the 250 micrograms. But then subsequent studies showed that irrespective of whether you are a responder or a non-responder, people responded to hydrocortisone therapy differently. When you give hydrocortisone, people's blood pressure either improved or did not improve. This response was not predicted by the results of the ACTH stimulation test. So then they said, what is the point in doing the test if I'm not able to predict who's going to respond and who's not going to respond? Then the next question comes, how can I then diagnose cortisol insufficiency in critical ill? People said, we'll just do a random cortisol level. But we all know that cortisol has got a huge diurnal variation. Most of the cortisol is synthesized in the morning, and then the rest of the day, the cortisol synthesis goes down. But this diurnal variation is blunted in critical illness, and so people felt a random cortisol level would be good. And some people said anything less than 25 in the face of stress is bad. Some people said less than 20 is bad. So these were all consensus saying that somewhere around 20, 25 or less cortisol in somebody with hypotension and shock it tells you that it's a relative cortisol insufficiency. Then a paper came in New England Journal of Medicine looking at free cortisol levels. As we all know, 80 to 90% of the cortisol is bound to cortisol binding globulin, and 10 to 15% is then either present as a free form or as bound to albumin levels. Both the globulin level and the albumin levels go down in critical illness and the free portion increases. So having an absolute level doesn't really make sense because we don't know what the free levels are. And this study clearly showed that free levels would be a much better way of looking at cortisol insufficiency than a random absolute cortisol level. However, free cortisol level is not available. It is available only for research purposes. We don't get access to it. So therefore, most centers or almost every center in the world does not have access to measuring free cortisol levels. So then the consensus came, don't measure anything. If the patient is in refractory shock, go ahead and start them on cortisol and see their response. So how do I define refractory shock? Refractory shock is defined as somebody who's adequately volume resuscitated and the hemodynamics are optimized. I have started them on appropriate antibiotic therapy. I have done appropriate source control. If I have done all these three and the patient continues to be in shock, then adding a hydrocortisone would be worthwhile. The question then is, should I add hydrocortisone or add hydrocortisone plus fludrocortisone? Hydrocortisone is a steroid which has got a very good glucocorticoid activity, but also has good enough mineralocorticoid activity where there is no particular reason to add fludrocortisone. Rather than going through all the studies, I'm going to talk about the most definitive study, the adrenal study that is the most recently published, a huge study from Australia that basically randomized patients to hydrocortisone 200 milligram per day as an infusion versus placebo in all patients with refractory shock. They did not show a mortality benefit at 90 days or at 6 months. But what all the studies of steroids have shown us so far is you can wean them off the vasopressors faster. Most studies have shown that we'll be able to get the patients of vasopressors at least by 1 day earlier on an average. And that is significant because there is 1 day less of vasopressor, 1 day less of complications, 1 day less of central lines maybe, and all of those would probably help us in the long run. So the current understanding is there is no particular test that's going to help you diagnose a relative cortisol insufficiency in the critical illness. The recommendation is to empirically start hydrocortisone 200 milligrams per day, not high doses. High doses have been shown to be harmful. 200 milligram per day as an infusion, and then continue it till the vasopressors are off and gradually taper it, not abruptly stop it. Maybe over a week or so is the current practice of managing critical illness related cortisol insufficiency. Thank you, Dr. Tapesh.
Thank you, sir, for the extensive reply. Then moving on to glycemia. So, sir, what are some of the important factors that one should consider in achieving a glycemic control in the ICU?
I think this is the other side of the coin. On one side, I'm going to give hydrocortisone to the patient. That is going to elevate my sugar. And on the other hand, I'm talking about trying to control the sugars. So the first, as a clinician, the first question is, why do we want to control the sugars? High sugars in critical illness have shown some deleterious effects. One, it can cause a pro-inflammatory response, which can make things worse. Two, it decreases neutrophil function, and therefore the ability to fight infections goes down. Three, it causes endothelial glycocalyx dysfunction. Therefore, there is more capillary leak and third spacing and now more fluid overload. Four, just by having high glucose, you can have osmotic diuresis, which can cause a lot of fluid shifts and can cause hypernatremia or other electrolyte disturbances, which are all harmful to the patient. So we need to treat hyperglycemia. Then the question is, above what level do we treat? We really don't have a very good evidence to say above what level we should treat, but most basic science researches have shown that any sugar above 200 probably causes all the above abnormalities that I discussed earlier, and therefore we should definitely not allow the sugars to go more than 200. But most consensus guidelines say anything more than 180, we need to start addressing the sugars in the ICU and not wait for it to go to 200. So the answer is, if the sugars are consistently more than 180, we need to start controlling them. Third, what is the target of sugar control that we need to do? There have been several studies. Initially, people try to say, I want to keep it 80 to 110, keep it very, very tightly controlled. It's called a very strict control versus a liberal control where they try to keep the sugars 140 to 180. Without going through every detail of every study, there have been two studies from Belgium, one in surgical patients, one in medical patients. The surgical patients showed mortality benefit with 80 to 110 kind of a target. But subsequently, the medical patients trial did not show any benefit, but showed harm because the 80 to 110 group had a lot of hypoglycemia in that particular study. The largest study so far is the NICE sugar study, again, in about 6,000 patients from Australia and New Zealand. It's a multi-center study where they looked at 80 to 110 versus 140 to 180. They also did not show any significant mortality benefit between 80 to 110 and 140 to 180, but showed increased incidence of hypoglycemia. So clearly, keeping 80 to 110 versus 140 to 180, no big difference in outcomes. But if you try to keep it lower and lower, there is a lot more chance of hypoglycemia. The question then is, so what? Several studies have consistently shown the risk of mortality is very, very high with every episode of hypoglycemia. So the more and more hypoglycemia you cause, the more and more mortality you are going to cause. So keeping the sugar lower and lower is going to create more hypoglycemia and maybe higher risk of mortality, but does not give too much of benefit. And the other factor that seems to affect outcomes in glycemic control is the variability of the sugar. So I have a patient who's got a sugar of 300 first hour, next hour 100. The average you would say is 200. Another patient may have a sugar of 180 and 220. He may also have an average of 200. So if you look at the average sugars, both patients have had the same average, but one had a lot more variability than the other. And this variability also seems to be associated with bad outcomes. So what we have learned from studies is, yes, we need to address hyperglycemia somewhere around 180 to 200 or higher, but we don't need to be too aggressive about it and try to bring it down to 80 to 110 because there is no mortality benefit by doing that. However, I would want to avoid hypoglycemia, which means I am better off keeping it at a slightly higher range than the 80 to 110 and try to avoid variability and keep the sugars reasonably stable. So based on all this, the current guidelines from SCCM published late last year clearly say the target would be 140 to 180 milligrams per deciliter across all critically ill patients for most part. There is also one other caveat here. Patients who are diabetics behave different than patients who are non-diabetics. Diabetics seem to tolerate hyperglycemia better. So for them, we don't need to really push the glucose down to keep it very strict. On the other hand, non-diabetics, hyperglycemia will hurt them. Hypoglycemia also will hurt them. In the diabetic group, hyperglycemia may not hurt as much, but hypoglycemia will definitely hurt them much. Even in diabetics, there have been two groups of patients. Patients whose sugars have been well controlled as an outpatient, who have an HbA1c of less than 7 coming into the ICU, they probably would benefit from good sugar control in the ICU. Patients whose sugars have been poorly controlled as an outpatient and have an HbA1c of more than 7, there is no additional incentive for us to be very aggressive. It is like bringing down the blood pressure too aggressively on somebody who's chronically hypertensive. Their body is used to a higher sugar. They function better with a higher sugar. For them, even 140 or 120 can cause symptoms of hypoglycemia, and we need to be careful. As of now, there are no guidelines recommending what the target should be for a poorly controlled diabetic, well-controlled diabetic, and a non-diabetic at this point of time. The general rule is 140 to 180, avoid hypoglycemia, avoid glucose variability. But I would go one step further and say if somebody has got poorly controlled diabetes, maybe we can allow their sugars to even go up to 220 or 240 and try to definitely not control them too aggressively in the acute setting.
Thank you. Thank you, sir, for the detailed answer. So then moving on to vasopressor, we had alluded to this earlier a little bit. So we have this vasopressor, phenylephrine. So it's not used commonly, though it's a very potent vasoconstrictor, and probably because of that, it leads to bradycardia and decreased stroke volume, decreased cardiac output. And we're not using it commonly. So is there any role for phenylephrine, sir, in the ICU?
As you rightly said, Dr. Tapesh, phenylephrine is a tricky drug. The first two catecholamines that were discovered were obviously epinephrine and norepinephrine. Subsequently, phenylephrine was a synthetic catecholamine. The advantage of phenylephrine is it acts only on alpha-1 receptors, does not act on alpha-2 receptors or beta receptors, and therefore it can potentially have some benefits. So where all I could use phenylephrine, one, it is an ideal drug for me to use as a push compared to norepinephrine or epinephrine. And one of the reasons for that is one, it has got only alpha effect. So I can safely push it in without causing tachycardia, arrhythmias, or aggravating coronary ischemia or increasing myocardial oxygen demand in elderly population. So one, if I have a patient who has acute hypotension, I have to do something urgently, I can probably consider pushing phenylephrine for that reason. Number two, unlike norepinephrine and epinephrine, phenylephrine metabolism is slightly different. And therefore, the uptake of catechols in terms of epinephrine and norepinephrine happens right away. Phenylephrine seems to be hanging around in the system long enough that the vasopressor effect of phenylephrine lasts for about 20 minutes compared to epinephrine and norepinephrine, which hardly lasts for 1 to 2 minutes once the push is gone. So if I am going to use a vasopressor peri-intubation or in the operating room where somebody is being induced with propofol or other medications that cause profound vasodilation, and I want to quickly restore their blood pressure up while I am getting ready other infusions, phenylephrine may be a good drug. There have been some retrospective studies that have looked at phenylephrine pushes. Most of them have shown that most patients, at least 50% of patients who need a phenylephrine push, end up needing a vasopressor infusion within the first 1 hour. But I still feel phenylephrine is quite useful purely because it is easily available. You could carry it in your pockets. In the ICU, you could probably push it any time of acute hypotension while your nurses need time to go and start the infusion with whatever vasopressor of your choice. That's the first place where I would probably use it. like you said, that the disadvantages of using phenylephrine as an infusion are one, it is pure alpha. It will increase systolic blood pressure. It will increase diastolic blood pressure. It will increase the mean arterial pressure. Studies have shown that these pressures can go up to 25%. But since it's a potent vasoconstrictor, it can decrease plasmic circulation. It can decrease the renal blood flow. The effect on cardiac output, like you said, is variable. It can cause a baroreceptor mediated bradycardia, in which case the cardiac output would go up. It can increase the afterload by squeezing the blood vessel. So if your ejection fraction is poor, again, you will do more harm to those patients and the cardiac output will drop. On the other hand, if your preload responsiveness, by squeezing the veins, it can increase the preload and increase the cardiac output. So the effect on cardiac output can be quite variable in terms of phenylephrine. The other disadvantage of phenylephrine is it's only about 1/10 as potent as norepinephrine. So every 1 mic of norepinephrine, you need 10 mics of phenylephrine. And therefore, you can imagine the doses will be as high as 200 mics per minute of phenylephrine. When you do that, you're ending up giving a lot of volume as an infusion, and that itself can be deleterious to the patients. And the other two problems also is one, there's a lot of tachyphylaxis to the alpha receptors. Alpha receptors get sensitized quickly, and then the effect of phenylephrine won't be very, very good. And it also increases pulmonary vascular resistance. Therefore, it should not be used in patients with right ventricular dysfunction. So, having said all that, is there still a role for phenylephrine in critically ill? I feel as a push, yes. Sometimes when patient has refractory atrial fibrillation with a rapid ventricular rate and is vasodilated because of sepsis and needs a vasopressor, if I give epinephrine, if I give norepinephrine, all of them are going to keep on stimulating the beta receptors and the heart rate cannot be controlled in a long period of time. Switching them over to a pure alpha at that point of time may enable us to control the heart rate better. So where I use phenylephrine is one, in situations where I need a push as a vasopressor, mainly during a peri-intubation in the ICU. Two, if the patient has a refractory AF with rapid ventricular response, which I am unable to slow down because of an ongoing beta agonist therapy in the form of epinephrine or norepinephrine, I may consider adding phenylephrine to cut down the doses of beta stimulants and see if I'm able to control the heart rate better. But there is no big randomized control looking at the effect of phenylephrine in vasodilatory septic shock in critically ill patients and mortality.
Thank you, sir, for the answer. So final questions, we have ECMO, and ECMO has become widespread in use. And now we have ECOR, extracorporeal carbon dioxide removal, which is coming up. So your comments are on the use of ECOR in the ICU.
Yeah. So again, ECOR is a new technology that is available. All we are doing is a relatively low form of ECMO where we are selectively removing carbon dioxide with a specialized filter. Why is that we need low flows? The first thing is carbon dioxide diffusibility is much better compared to oxygen diffusibility. And therefore, with a little bit of flow, we are able to clear the CO2 a lot more faster compared to ECMO. So one, it is easy for us to clear ECMO with low flows. And it's a low flow, the advantage is I can put a smaller axis, the complexity of the process decreases, and I can probably do in any ICU which will do hemodialysis, which most ICUs will be able to do hemodialysis, but not every ICU will be able to do something as complex as an ECMO. So it is a easily available tool that any ICUs can use, and we can probably utilize in the critical care setting. Second question is, where all would I use it? The most important point where I would want to use it would be one, in ARDS patients. ARDS is a heterogeneous syndrome where the primary pathology can be predominantly a shunt physiology or a dead space physiology or both. If for some reason I am unable to ventilate a patient, let's say I'm able to maintain the oxygen saturations with a reasonable driving pressure. We all know we want to do lung protective ventilation with 6 ml per kilo tidal volume, plateau pressures less than 30, and driving pressures as low as possible is what we would say. Sometimes the lung compliance is so poor, dead space is so high, I am unable to do any kind of ventilation with the tidal volumes I give. Even when I go down to 4 ml, I'm still unable to ventilate the patient, and CO2 is very high. Those patients would be ideal to add ECOR, because then I can remove CO2 that way and put less strain on the lung. Animal model experiments and physiological studies with ECOR have shown decreased pulmonary inflammatory markers with ECOR that happens in patients with ARDS. So that is one place I can do. Second place I can consider is in patients with COPD and or asthma, where I can use ECAR to either prevent them from intubation or try to wean them off the ventilator. There are patients where I'm not able to wean them off the ventilator because of persistent hypercapnia. I can probably use ECAR to try to get them off the ventilator and then put them back on non-invasive ventilation and try to get them off. So those probably would be the three main indications for me to do ECAR in the ICU. There have been a few studies. I would just quickly name the studies. The first study is EXTRAVENT, which looked at 80 patients with ARDS. They did not find survival benefit, but they could show that the driving pressure and the amount of impact or power that we put on the lung is much lower when we use ECAR compared to anything else. Second is Supernova trial, again in patients with ARDS, where they looked at the feasibility. They found about a 60% survival, which is very good for ARDS. Most patients with ARDS have about a 50% mortality. They used ultra protective lung ventilation with only 3 ml per kilo with ECAR, not even 6 ml. Half of that with ECAR, they were able to get away with it, and the patients did well in the Supernova trial. The third trial is the REST trial, where patients were put on conventional mechanical ventilation versus ultra-protective lung ventilation with ECAR. They did not show any significant mortality benefit in these particular patients, but all these studies have given us some kind of a positive vibe saying that this is a tool that we should probably consider using in our ICUs for these specific indications I have given you. In COPD and asthma, predominantly there have been a lot of case series. There has been one study called Vent Avoid study, where they try to see if ECAR is going to be preventing patients from needing mechanical invasive ventilation. The results of the study are not out yet. ECAR was also used during COVID for these purposes, and there's a lot of data to say that COVID pneumonias, ECAR would be one more tool that we could use and probably has a good role there. Now there are several machines out in the market. Some of the machines come with where you can do CRRT and ECAR, or only CRRT, only ECAR, so you don't have to invest in two different machines. So looks like there is more interest in ECAR that is coming up, more evidence is emerging. But the way I look at ECAR is, one, lung protective ventilation in ARDS, two, avoiding intubation in patients with COPD, three, trying to wean patients of COPD from a ventilator to a non-invasive ventilator using ECAR, four, in disease, especially COVID, where there is a lot more case series, we can consider trying to eliminate the CO2 in those patients. Thank you so much, Dr. Tapesh.
Thank you, sir. I think that was the last question. So I thank Dr. Venkataraman, sir, for his detailed and clear answers emanating from extreme and profound knowledge and experience. Thank you, sir. Thank you very much for educating.
Thank you, Dr. Tapesh. Good night. Thank you so much. Thank you for
thank the audience. Sir, there is a question. Shall we take it up?
Yeah, please.
So what dose of vasopressors nutrition need to be within? What can you clarify?
Yeah, I don't think there is any particular dose specific cutoff that I would use. What I would probably do is, if the patient has active shock that is getting worse, where I am escalating the doses of vasopressors, I have not fully resuscitated the patient, probably better to avoid giving enteral nutrition during that period. Most of that would happen within the first maybe 12 hours, maybe up to 24 hours. At which point of time, I think the vasopressor dose should stabilize or start coming down if rest of the problems have taken care of. Then I would initiate low volume enteral nutrition, see the tolerance, and gradually titrate up. There is no urgency for you to give full target of calories and proteins within the first 24 or 48 hours. So I would definitely not do it during active resuscitation, active escalation of vasopressors. Once all that done and the vasopressor dose is plateauing or coming down, start gradually and increase your dose of nutrition. I don't think there is any absolute number that has been recommended by any society or guidelines or any studies so far.
Thanks, sir. So again, there's a question, role of Ivabradine in sepsis, sir.
Okay, so Ivabradine is a drug that decreases sinus tachycardia. Data in sepsis is not very high. There is some data in heart failure to say it may improve outcomes in patients with heart failure. The reason we actually give Ivabradine sometimes is purely out of desperation. any catechol we use triggers the heart rate to go up. Patient has got fever, patient has got a high sympathetic drive, everything increases the heart rate. If it is sinus tachycardia beyond a certain point, then we are worried about two things. One, the higher the heart rate, lower the diastolic time, therefore there is going to be impaired coronary perfusion. Two, higher the heart rate, increase myocardial oxygen consumption. So one end, I have decreased coronary time, filling time, and two, I have increased myocardial oxygen demand. Both can precipitate a myocardial ischemia. So that would be one of the important things I would worry about. Two, when I have high heart rate, my diastolic time goes down. So if I have a systolic dysfunction or a diastolic dysfunction, especially diastolic dysfunction, then you can unmask the diastolic dysfunction by inducing tachycardia in patients while you're adding vasopressors. So one end we have to use vasopressors, other end we don't want too much tachycardia because we can precipitate diastolic dysfunction and coronary ischemia. So out of desperation, we need a drug that would slow the heart rate without dropping the blood pressure, and we end up using Ivabradine in the situation. There is no major randomized control trials in sepsis. In heart failure patients, there seems to be some data to say that it can potentially improve mortality in patients with systolic heart failure.
I think that was about it, sir. So we've answered a couple of questions. So I thank you once again, sir, and I thank the audience for their patient hearing. Namaskar, and it will be up on our YouTube channel in a couple of days after putting it through a little bit of editing. Thank you, sir. Thank you very much. And
Thank you so much, Dr. Tapesh. Nice being part of the session. Thank you so much. Have a good night. Bye.
good night.